Hello friends, in today's lecture we are going to talk about how to interpret and make a diagnosis of cardiac conditions only on the basis of chest x-rays. Chest x-ray reading is an art itself and requires good knowledge of human anatomy as well as experience to make a right diagnosis. This is the first lecture in the pediatric radiology series and subsequently more informative lecture on this topic will be uploaded. So we all know that echocardiography has become the gold standard to diagnose heart diseases. However, chest x-rays can provide very useful information as well. Chest x-rays are usually very easily available and less time consuming. Unlike echo, chest x-rays are not single observer dependent and multiple opinions can be taken. Also, the fact that additional information can be gained by chest x-rays like lung parenchyma, airway structures, vascular structure, which is usually not possible with echocardiography, and all this makes X-ray an invaluable tool in diagnosis of cardiac conditions. So the learning objective of this session are to learn how to measure heart size and determine if cardiomegaly is present or not. Then to learn what are the structures that form a cardiac silhouette. Then we will look at the individual cardiac chamber enlargement and their causes. Then we will also learn how to look at great arteries and vascular marking in the lung fields. And finally, we will have a look on some of the classical X-rays pertaining to heart diseases in pediatric population. So the first thing is to determine whether the heart size is normal or not. So how to measure heart size? The index which is commonly used to measure heart size is CT ratio. So how do we calculate CT ratio? We have to draw a line from the center of the thorax passing through the spinous processes of the vertebral column. We have to ensure that the film is not rotated, right? Now from this center line, we have to make a line which goes toward the maximum convexity on the right side, and similarly a line which goes to maximum convexity on the left side, right? We call these lines A and B. Similarly, we draw a line measuring the maximum internal diameter of the thorax ranging from inner side of the both ribs from one end to other. We call this line C. The CT ratio is basically A plus B divided by C. Now how to interpret? A ratio of usually more than 0.5 indicates cardiomegaly in older children and adults. In newborn, however, a ratio of more than 0.6 is taken as a marker of cardiomegaly. Now whenever the cardiomegaly is present, always look for the degree of inspiration as well, because in an expiratory film the CT ratio may be falsely enlarged. Now whenever you detect cardiomegaly, you must also remember that it mainly represents volume overload and not pressure overload. In the conditions when there is pressure overload like concentric hypertrophy of the left ventricle or right ventricle seen in cases of aortic stenosis or pulmonary stenosis, then there is no cardiomegaly as such, but just the hypertrophy of the ventricular chambers, right? So apart from the volume overload, cardiomegaly may also be seen in pericardial effusion. We have already discussed it may also be seen in expiratory film and also sometimes in flat chest when the anterior-posterior diameter of the chest is very less. So there is relative cardiomegaly, again falsely seen in these patients. Now when we talk about interpretation of the heart structures on the X-ray, then you must remember what is the normal anatomical location of the heart in the chest cavity and what are the borders of the X-rays, border of the heart make on the which make the cardiac silhouette. So if you see in this X-ray and if you see the normal location of the heart in the anatomical position, you will see that the right side of right border of the heart, the upper part is found by the superior vena cava, this part, and the lower right border is found by the mainly right atrium. Similarly, on the left side, the upper part is formed by the descending aorta and the aortic knob. Some part is formed by the main pulmonary trunk. Very little is contributed by the left atrial appendages, and mainly it is formed by the left ventricle, right? So this you have to remember. Now, cardiac salute can also be appreciated on the lateral view. In the lateral view, you will see that this is the normal anatomical position of the heart in the lateral view, right? So it is predominantly the right ventricle which is forming the anterior border of the heart, right? The posterior border and the posteriorly the main component is left ventricle. In the lower part, in the upper part, it is the left atrium. Then the upper portion in anteriorly is formed by the main pulmonary trunk, and then you have arch of aorta and descending aorta going superiorly and then posteriorly. When interpreting cardiac salute in a newborn or a neonate, you must also remember that usually there is a thymic shadow which is seen as a sail sign or a smooth uh, homogeneous opacity in the anterior mediastinum, and you have to be careful while interpreting cardiac salute in these newborn. Now we'll be looking at individual chamber enlargement, and we'll see that how we can diagnose individual chamber enlargement on the basis of X-ray itself. So we'll first go by left atrial enlargement, right? So you must have noticed that left atrium contributes very little to the cardiac salute in the AP view or the PA view. It is mainly located in the posterior part of the heart, so it is mainly seen in the lateral view. So what will be the finding in the PA view when there is a left atrial enlargement? So if there is mild LA enlargement, it can only be appreciated on a lateral view by the posterior protrusion of the left atrial border, right? Like these yellow arrows. So normally this left atrium will not be protruded posteriorly, but in case of mild atrial enlargement, the first sign you will see is on a lateral view that it has protruded posteriorly, right? And you may not be able to appreciate anything on a PA view, but then if it further enlarges, then there are signs visible on a PA view as well. So these are the classical signs. So first of one of the commonest sign is this double density sign. So what is double density sign? You will see double shadows, right? Because of the enlargement of the left atrium, you will see that two shadows are visible if you look at the right cardiac border, right? So this is called double density sign. This is because of the enlarged left atrium. Then the left cardiac border will become more convex, like, so you can appreciate this also. And then finally, because it is located beneath the left main bronchus, it will lift the left main bronchus, right? So there will be widened carinal angle. So this left main bronchus will be lifted upward and you will see a widened carinal angle, usually defined as more than 75 degrees. So these are the signs of left atrial enlargement on a PA view. Right. Next we move on to left ventricular enlargement. So how will we see left ventricular enlargement on a PA view and a lateral view? As you can see in this diagram, left ventricle mainly forms the left border of the heart, and posteriorly also it forms the lower border of the heart. So if left ventricular enlargement is there, in a PA view you will see that apex is shifted down and out like seen in this figure, and then you will see that posterior border is displaced further and it will reach the vertebral column, and the IVC line which is usually visible will not be visible anymore, right? So these are the two signs of left ventricular enlargement which can be easily appreciated on a PA view itself and also on lateral view. Talking about right atrial enlargement, so where is the right atrium in the PA view? So right atrium predominantly forms the right lower border of the heart. So if it gets enlarged, there will be increased prominence of the right lower cardiac border. So this will become prominent. Obviously there will be CT ratio will be enlarged. Right ventricular enlargement, you must have noticed that right ventricle does not contribute to cardiac salute in a PA view. It only contributes to the cardiac salute in a lateral view. So it is not appreciated on a PA view, and in a lateral view you will see that there will be filling of the retrosternal space. So if it gets enlarged, you will see filling of the retrosternal space as can be seen in this figure. Now we'll talk about how to interpret great arteries on the chest X-ray. So the main pulmonary artery prominence will be seen as prominence of this knuckle on a PA view, right? So normally if you see a PA view, then you can draw a straight line through the left cardiac border. Similarly, if you draw the straight line on the left cardiac border in this diagram, you will see that there is a prominence or there is a bulge going beyond this straight line. That indicates that there is pulmonary artery enlargement. It can be seen in post-stenotic dilatation like in pulmonary valve stenosis. It can also be seen in any condition which causes increased blood flow through pulmonary artery, as can be seen in many left to right shunt conditions like atrial septal defect or ventricular septal defect. Then any condition leading to increased pressure in the pulmonary artery like pulmonary hypertension. Please remember that occasionally it can be seen as a normal variant in adolescent girls. Now pulmonary artery hypoplasia will be seen as a increased concavity, right? So this depression like thing will be seen on a PA view if pulmonary artery hypoplasia is there. So what are the conditions which can lead to pulmonary artery hypoplasia? Mainly seen in either tetralogy of Fallot and tricuspid atresia. So how will then aortic enlargement will be seen in a PA view? So aorta, you know, it is going like this, contributing very little to the upper border of the heart, upper right border, and then aortic knob, and then it is becoming descending aorta, right? So with aorta gets enlarged, then all of these structures will become more prominent. So this they will be seen like this. So ascending aorta, then aortic knuckle, and even your descending aorta will become more prominent, right? So aortic enlargement can be seen in conditions like tetralogy of Fallot, where there is overriding of aorta, then aortic stenosis due to post-stenotic dilatation, then coarctation of aorta, patent ductus arteriosus, and also in conditions like Marfan syndrome or systemic hypertension. Aortic enlargement can also produce a sign of 3. This is called figure of 3 signs, which is seen in coarctation of aorta. So you can see this beyond the coarctation and post coarctation, you can see both enlarged aorta before and after coarctation, so leading to a figure of 3 appearance. Another thing which we should carefully look at when we are interpreting chest x-rays is vascular markings, right? So normally these type of pulmonary vascular markings are visible on a PA view of chest x-ray. So there is gradual tapering towards the periphery. So the pulmonary vasculature is only visible in the medial 2/3 of the lung fields, and lateral 1/3 of the field is devoid of any vessels. This is the normal finding. They are more prominent in the lower lungs, and usually the upper lungs do not have any vascular markings. And if you see the diameter of the descending branch of right pulmonary artery as marked by these arrowheads, it is equal to the diameter of trachea. This is very important to know, right? What happened when these pulmonary vascular markings become increased, right? So this diameter of descending branch of right pulmonary artery will exceed the diameter of trachea, as can be seen in this x-ray. Then there will be prominent vascular marking in the upper lobes, which were not there in a normal pulmonary vascular marking. Then they will extend to the lateral third. Usually they do not extend into the lateral third of lung field. So these are all signs of increased pulmonary vascular markings. Now, what are the causes which can cause increased vascularity? So left to right shunts like ASD, VSD and PDA. Then certain cyanotic heart disease with increased pulmonary blood flow like TAPVC, truncus arteriosus, double outlet right ventricle without pulmonary stenosis, and complete TGA without pulmonary stenosis. They will lead to increased pulmonary blood flow. And sometimes some hyperkinetic states like severe anemia, thyrotoxicosis, arteriovenous malformation can also lead to increased pulmonary vascular marking on a chest x-ray. Now pulmonary vascular markings can sometimes be reduced also. So it is characterized by small size of pulmonary vessels at hyla and within the lungs, and lungs may appear to be hyperlucent. Now what are the causes which can lead to decreased vascularity? So right to left shunts, right-sided heart failure, pericardial effusion or constrictive pericarditis, and pulmonary embolism will lead to decreased vascularity of the lung fields. Now finally we will look at some of the classical X-rays and why they are named so, right? So you can also guess these X-rays. This is one of the very classical chest X-ray showing one of the very classical cyanotic heart disease. So as many of you must have guessed it, this is a boot-shaped heart, named because it appears like a boot, mainly because there is an upturned apex and there is hypoplastic pulmonary artery which gives it appearance of a shoe, and also there is pulmonary oligemia. Another classical X-ray is this globular kind of heart, which is, and there is a cardiomegaly, and you may have noticed that the base is very narrow. So this is egg on a string appearance, right? So this is seen in transposition of great arteries or TGA, characterized by narrow waist, increased vascular markings, and abnormal convexity of the right atrial border. Finally, this is the final X-ray. Again, a very classical X-ray seen in a cyanotic heart disease. So this is snowman appearance or figure of 8 appearance, right? So this is seen in total anomalous pulmonary venous connection supracardiac variety, right? Not intracardiac variety. So supracardiac TAPVC has snowman appearance on a chest X-ray, and it is seen because of the dilated superior vena cava and dilated left vertical and innominate vein, which forms the head of this snowman, right? So that's all. Uh, we'll post more lectures on this series. We'll learn how to interpret X-rays in different kind of scenarios. So keep watching, and if you are new to the channel, just subscribe and like the channel. Thank you.